Hi, welcome back. By now you have probably understood that our main goal is to detect coronary heart disease as early as possible. We believe that the APGram is the best method to detect and measure this underlying cause of coronary heart disease, and that the systolic shift of an aortic echo wave is the main underlying cause of coronary heart disease. In this brief review, we will link together several key factors. To simplify our presentation, we will use semi-quantitative concepts instead of precise numbers. This shows the pressure changes during a heartbeat. The orange line at the top represents the pressure changes in the aorta. The purple line represents the pressure changes inside the left ventricle. During systole, blood cannot flow through the coronary arteries because ventricular pressure is greater than aortic pressure. This area is shaded in deep blue. Immediately before aortic valve opening and after aortic valve closure, there is partial flow in the coronary arteries. The shading in this area progresses from blue to red. The pressure gradients in the rest of diastole result in full coronary flow. They are shaded in red. But you may ask, what is the source of the pressure gradients during diastole? The top portion of the previous graph represents the arterial pulse wave. Notice that the ascending limb of that pulse wave corresponds closely to the ventricular pressure changes. The descending limb, however, has a very different slope, not at all symmetrical with the first one. This is because the arterial pulse wave is the sum of two different pulse waves. Is a primary forward-moving wave created by the action of the left ventricle and a secondary backward-moving echo wave created by the reflection of the primary wave from peripheral resistance sites. This can be illustrated by a simplified drawing of the primary and echo waves. During diastole, the echo wave provides the pressure gradient that is needed for coronary blood flow. If the speed of travel of the echo wave is decreased, it arrives later. This results in a shift of the echo wave towards the diastole. This is the period when excellent coronary blood flows are possible because ventricular pressures are low. If pulse wave velocity is increased, on the other hand, the echo wave returns sooner. This results in a shift of the echo wave towards the systole. This is the period when coronary flow is decreased because ventricular pressures are high. If pulse wave velocity is markedly increased, there is a further shift of the echo wave towards the systole. At this point, coronary blood flows may cease altogether. We will now look at the results of progressively greater systolic shifts of the echo wave. In the initial stages of systolic shift, The main effect is a decrease in coronary blood flow, as we have seen previously. In more extreme stages of systolic shift, we have further reductions in coronary flow, accompanied by an increase in systolic blood pressure as the echo wave merges almost completely with the primary wave. When the systolic shift has resulted in a large enough decrease in coronary blood flow, symptoms of coronary insufficiency appear. Further shifts may lead to heart failure due to the increased workload on the left ventricle. This is a three-dimensional view of equal increases in systolic shifts. Notice how little effect early shifts have on coronary blood flow or blood pressure. On the other hand, with each further increase in systolic shift, the changes do not just increase linearly, but appear to multiply and compound rapidly in terms of coronary flow decrease and increase in blood pressure. This summarizes the links between the cause and effect of the systolic shift of the echo wave. The cause is an increase in pulse wave velocity, and the result is insufficient myocardial perfusion. But what can cause this increase in pulse wave velocity? First is arteriosclerosis, which decreases the elasticity of arterial walls. This develops slowly, progressively, and silently due to aging. Second are increases in blood pressure, which increase the tonus of the arteries. These increases in blood pressure may develop suddenly and rapidly due to